Word.
Thank you.
All right. Well, good evening, everyone. As Nick mentioned, if you have any accommodations or any technology issues or needs, please do let us know. Raise your virtual hand, raise your actual hand, put something in the chat. We want to make sure that everybody finds this event accessible. So let us know if we can help. I am Lindsay Owen. I'm the Executive Director of Disability Rights Vermont. I am also the Vice President of the Vermont Coalition for Disability Rights. I want to thank everyone for being here today. Pause. I am a white woman. I use she, her pronouns. I am approaching 40 years old and I wear glasses. And so I wanted to just give a visual description before we begin. So this is our second Disability Awareness Day event for 2023. The theme is We Are Your Neighbors. What does that mean? It literally means we live next door, we go to the same grocery stores, attend the same schools, need the same hospitals, walk the same sidewalks, drive the same streets, and work in the same community. We are parents, we are students, we are children, we are teachers, lawyers, entrepreneurs, and so much more. We have all the same opportunities. But our environment, our neighborhoods, our towns, and our state put those opportunities further out of reach. So why aren't all of these parts of our lives equal to others in our neighborhood? We are here today and every day to be seen, to be heard, and to be included in all aspects of our daily lives and in the conversation and the implementation of change to make the state better for each and every single Vermonter, including you and me, regardless of disability. The disability community is large in our state, yet people with disabilities continue to feel ignored when they raise issues around access. We hear reports of people that experience multiple marginalization, like being a disabled person of color or part of the LGBTQ+ community, and having a disability at the same time feeling even more left out. And yet people with disabilities are unnecessarily unable to access equal education, employment, healthcare, and participation in this democracy. People with disabilities are having their rights violated, their children taken away, and they are dying at alarming rates with little attention or follow-up as to why and how and what can be done to prevent or slow this down. Conversations are happening around us, about us, and yet barriers exist in our efforts to include us. For example, town meeting day is an opportunity for all of the voices of our unique neighborhoods to be heard. But some voices have been left out, despite federal and state law demanding that people with disabilities receive accommodations or modifications to practices and places in order to ensure equal access and participation. Unintentionally or not, illegally or not, we are here today to share stories that shine a light on these hard truths, and hopefully many, if not all, of you will leave this space tonight with an open mind and an open door to your neighbors with disabilities. Thank you again for being here. As I said, this is an opportunity to hear from folks in the community, to hear what their experiences have been, and to share stories. This is not an opportunity for us to be able to answer and address individual questions or concerns. If you do have an individual question or a concern that you would like paid attention to, please contact Nick at VCIL, the Vermont Center for Independent Living, and he will put his contact information in the chat. And if you need help accessing Nick, again, before we close today, we'll have an opportunity for anyone who needs assistance reaching out about an individual issue to do that. I will hand it over now to Karen, who's going to move us through the presenters and the event today. So thank you, Karen.
Thank you, Lindsay. I'm Karen Lafayette, and I am the Vermont Coalition for Disability Rights Coordinator, and I am a 68-year-old white woman, and I'm wearing a black hat and a green scarf, trying to welcome in spring that came and then went today. So thank you all for participating. I'm going to move us from neighbor to neighbor, and we're going to start our discussion tonight with Kirsten Murphy. Go ahead.
Great. Thank you so much, Karen and Lindsay.
Hi, everyone. This is Kirsten Murphy speaking. I'm the Executive Director of the Vermont Developmental Disabilities Council. I use she, her pronouns, and by way of a visual description, I am a white woman with curly, short-cropped, salt and pepper, mostly salt at this point, hair, and big dark-rimmed glasses, and I'm wearing a blue shirt with a green scarf. Also a green scarf, so it's a theme tonight, huh? So I'm going to talk a little bit about housing and only have 8 minutes to present to you what is really a little bit of a longer presentation. The Developmental Disabilities Council, in collaboration with our colleagues at Green Mountain Self-Advocates, was charged under a bill that passed last session with developing a research brief. So that's one way to tell a story, is through some research. A research brief about the types of housing models that other states use that could expand the options available, specifically in this case to Vermonters with developmental disabilities, though we think that the lessons learned from this study are more broadly applicable to the whole disability community. And I want to stress that this brief and the work that we're doing around housing is there's a lot more work to do. So this is kind of a more like at the not the very beginning of a conversation, but still there's a lot more that we need to learn. So I will be glad to talk to anybody offline that hears what I have to say and wants to know more about the work that we did, or to talk about housing more generally. So the research question that we were asked by the legislature to explore is, what are other states doing to bring housing options to scale, so enough to really make an impact, for recipients of home and community-based services who have intellectual and developmental disabilities. So we expanded our charge a little bit and also did some work with focus groups to learn more from both self-advocates and parents of individuals with IDD about their experience with housing. And we also, because we're so frequently asked, the first thing housing developers want to know is, well, how many units do you want? So we really made an effort to come up with a number and have some research behind what that number that quantifies our need, that says, how many units do you need? So, I'm just going to go over 4 kind of key findings that were in this report, and then I will leave a link to the report in chat after I get done talking. First, when we talked to stakeholders, and that was providers, self-advocates, family members, across the board, there was a clear agreement that our system for people with IDD is overly reliant on one model, which is shared living. It's not that that's a bad model, it's just that we're very, very heavily reliant on that model. And people were looking for more choices in what their service-supported housing could look like. We also were really struck, we were really struck by the fact that while families and self-advocates might be seeking sort of slightly different things in the models that they wanted, again, across the board, there was widespread agreement, and this speaks to the "we are your neighbors," that one of the biggest problems for people in their residential situation, whatever that looked like, is that they felt lonely, that they felt like they weren't having enough access to community, they weren't feeling a part of something bigger than themselves. And both families' biggest fear was that a son or daughter with a developmental disability would be lonely. And self-advocates talked a lot about loneliness. And I found that really striking. I mentioned that we made an attempt to quantify what this particular group of people already in services who happen to go through the developmental disability program. Doesn't mean that other programs don't also need housing. But our best estimate, based on a multiplier that is based on research that came out of Ohio, is that we need 600 units of permanent supportive housing for people already in services with intellectual and developmental disabilities. We could right size the way we are deploying other models of housing, like group homes, particularly shared living. And people would migrate into another model if it was available. And our system could absorb 600 units where people might, migrate. Now, I have also heard from many people who are served through Choices for Care who experience physical disabilities, in particular physical disabilities, that they too also have the same sort of need for more choice in service supported housing. So we know that 600 is far too low if we're talking about the disability community overall. So I want to talk about this model called service support, or called permanent supportive housing. This is a model, this is the model we focused on because it's what other states, and the question was, what are states doing? Not what private companies are doing, but what do state governments do if they want to scale up affordable housing where people are stable, they aren't moved around, they have the services and supports they need. Permanent supportive housing can look a lot of different ways, and we have described 8 different versions of it in our report. It can look like an apartment building that is affordable housing, and a certain percentage, not more than 25%, that's across the United States, that's the accepted number, are set aside for people with disabilities of one kind or another. Those units can be very creatively designed so that if they're newer units, they have accessibility built into them and the ability for people to age in place. What makes this supportive housing is that there are services assigned to the building that will assist people with accessing services and supports in their neighborhood, being better tenants, figuring out how to use the bus system, whatever it is. But there are some services. The individual not only gets the services that they receive through their home and community-based program, but there's an other extra layer of services attached to the building. So permanent supportive housing can also look like units scattered across a neighborhood with a similar sort of service wraparound that assists people living in those units. And I wish I had time to describe some of them in what we saw in more detail, but I will let you see the link to the report. We talked about some things in Connecticut, California, et cetera. Last finding I want to point out, actually 2 findings very quickly, that states in general benefit a lot, and this is something Vermont doesn't have, by having an organization that is a bridge between the housing provider world and the service world, the human services type delivery world. And in a lot of states, that looks like an ARC, or it looks like Easter Seals, or it looks like a private nonprofit. And for whatever reason, good, bad, or indifferent, Vermont just doesn't have that bridge. So in Connecticut, a lot of service supported housing is being built, and it was the ARC that joined together the funding stream from housing and the funding stream from services. So that's a gap we somehow need to fill, not necessarily in the same way, but we need that link between the 2 worlds. And finally, one of the findings that we're really, really clear about is people with disabilities are not getting their fair share of money being spent on housing. Housing needs to be paid for by housing money. We've had a tendency in our state to kind of think that human services will somehow come up with these new housing models and pay for them. That's not where the money for housing should come from. It needs to come from all the many different benefit programs that flow through housing services and HUD. So we all, in our advocacy community, need to get better at figuring out what the policy levers are in that world, and some of those are described in our report. I have taken 1 minute longer than my allotted time, and I hope that I get a chance to dialogue with some of you all later at some other time about housing. Thank you so much.
Kirsten, thank you very much. And we're going to move on to talking about workforce, and that's Rebecca.
Hi, everybody. So I'm Rebecca Bissett, and I'm coming in from Howard Center Developmental Services. and I'm here to talk to you a little bit about my experience with the workforce crisis and the important essential work that we're doing here at Howard Center. So my role is a senior manager, and I work in the residential long-term supports and services, overseeing our level 3 licensed residential care homes. Together, we support our most medically fragile and especially vulnerable adults. Most of our residents face significant medical challenges and cannot be cared for by even the most skilled shared living providers, and in many cases surpass the level of care that's provided in nursing homes. This is because in addition to their significant medical needs, our residents have intellectual and developmental disabilities or autism and co-occurring mental health and psychiatric needs. And our staff navigate the unique needs of each individual resident 24 hours a day, 365 days a year. I can confidently tell you that my staff are everyday heroes. The residents in my programs require such a range of support. While some might possess a level of independent skill, many of them require significant or total assistance with every activity of daily living. So that means dressing, bathing, toileting, eating, administering medications, scheduling and going to medical appointments, providing companionship, and so much more. And our situation is unique as an RCH in that we don't have access to on-site 24/7 nursing. So what that means is that our staff need to be trained by and work closely with our overseeing nurse, who delegates them to administer medications under that nurse's license. They're also delegated to perform specialized care procedures, so nebulizer treatments, catheter care, injections, dysphagia diets, and to use durable medical equipment like Hoyer lifts and specialized wheelchairs. The staff that work in these programs are essential, and they truly hold the safety, the lives of each of these residents in their hands each and every day. The work they do requires a skill set that embodies social work, L&A skills, medical skills, compassion, and a desire to meet challenges every single hour of every shift that they work. They add so much value to the lives of our residents, and I can't tell my staff enough how amazing they really are. And that said, we're still faced with this unprecedented crisis. Our workforce decimated. Since the pandemic started, we've watched as businesses have closed down and shuttered, programs have ended, events have been canceled, and for a while, the whole world seemed to stop moving. Throughout that time, our direct support professionals have quietly pressed on to continue to support people, support themselves. They continued to work hard to provide person-centered care and be the face of normalcy during the most challenging times we've experienced, when even friends and family weren't permitted to visit these programs. Many times, direct service professionals have been the only social network, the only safety net that a resident has had. And it has come at an incredible cost, often at expense of the time with their own family, time to take care of themselves, time to meet their own needs, and time to breathe while the rest of the world seemed to stand still. Today, our staff are continuing to work up to 80 hours a week to help us ensure safe and appropriate staffing levels, but this is not sustainable. Staff from other areas are also jumping in to help. We have supervisors in various levels of management, all the way up to the tip top of developmental services, that have continued to step in and bridge gaps so that we can meet our clients' needs. So I'm here today because we need your help. It's time to write a new chapter in this book. It's time to rebuild a stable and sustainable workforce of dedicated professionals who really want to do this work, and we cannot do it alone. Much has been done in the last year to recruit and retain staff, and we have seen some improvements. There's still a lot more that we could do. Last year, we saw an 8% budget increase that we were very grateful for. Many of us advocated to increase wages and offer incentives like sign-on bonuses and relocation funds to get new staff. And while this has helped by stopping our vacancy free fall, we continue to sustain a 24% vacancy rate across developmental services, which, by the way, has also in the last year experienced a 36% turnover rate of regular staff. And that is just a short drop from a 46% turnover of regular staff the year prior, 2021. As a matter of fact, developmental services continues to have a higher turnover than other areas of the agency. And if you could just imagine for a moment the impact on the residents who live here as they essentially watch their caregivers leave in droves. Imagine the implications of training new staff and rebuilding relationships with residents and essentially starting over from scratch. We just have to do better. We're competing with local and corporate employers who offer more money for non-human service jobs, jobs that don't require the physical, mental, and emotional commitment to care for our most valuable neighbors, or vulnerable neighbors, sorry. We're competing with the onset of gig work and social media marketing, where people can earn a significant hourly wage right from their cell phones. And I'm not saying that that work isn't important, but I am saying that we need to incentivize the very hard work that supports human beings every single day. And your friends and family, your neighbors are all doing this work, and they have spoken. When asked what would help you remain in direct care, 74% of those people replied higher wages, and 59% of people polled said they cannot live on their current salaries. We have to do better. And so to invest in our workforce is to invest in your neighbors and our residents, our staff, our supervisors. They are all your neighbors.
Rebecca, thank you so much for that. And now we're going to hear a little bit about the personal side of workforce and housing from David, and Emily may join him.
Okay. Yes, take it away, David.
Hi, my name is David Fry. I'm a self-advocate. I'm a member of the Champlain Voices. My agency is local Greenmount Self-Advocates group, and I wear a lot of hats in the disability world, including being on the board of the DD Council. I'm a man who has a home, the community. I am a man who has a home, the community-based services. I'd like to share my perspectives on the two important topics: the workforce I depend on, the community support of housing. I feel that even before the pandemic to now, services have always been short of staff. I feel that the two agencies I've worked with, Howard Center and CCS, every single year has been trying to fight to keep people on board, to keep them from leaving. I think it's a real struggle to keep people on because they're getting paid, and they're not getting paid enough and to being with. By having a lack of people not working in these services, because the strain on us people with disabilities to not have that help. I've had a community access person say to me, I can't afford to have this job because I'm not being paid, and that I should be paid, and she had to leave to take another job. It seems like that pattern that we are just always seeing. If we could just get paid what we are worth every single year, we wouldn't have the lack of people to work in these services. People might clap. As for housing, I would like to say that I've had a journey and I've had many share living providers, all different, and with their variety of positive and negative. I don't want to live with people who are overly neat. I want to live with people who share more of my lifestyle and definitely not vegan.
David, did you need any more time?
Yes.
Go ahead.
I have moved on to a living on my own. I would like to say though that I've always been thinking that before people move into those share living provider situations, and some decisions should be made ahead of time so that everyone knows that people with disabilities can have whoever they want to come over to visit and can eat what they want to eat and need to have their privacy. That no one can get their room into their room if they don't want them to. So I'm thankful that the home community based services setting rules address all of that. They are going into effect now. Currently, I live on my own apartment. Even though I'm more independent, it's not an ideal. I have to drive my car, get everywhere, and many people don't have the luxuries. I'm not on a bus line. My idea would be live in the central to everything. I can get from point A to point B, even if I didn't have a car. I could take a bus, take a taxi, or I could rely on someone to come get me. Where I am, I don't have to choose, have those choices. I think I would be better to be mentally, emotionally, to be part of the community. I don't feel like I have that now. I have so much to offer. Thank you so much for being here, and I look forward to your questions and comments later in the program.
David, thank you so much for that perspective. Just like all of our other neighbors. Now we're going to hear from a couple of Vermont occupational therapists, Karen and Ella.
Hello, everyone. My name is Karen Downey, and I am an occupational therapist here in Vermont, having worked in the public schools for over 35 years. Presently, there's a shortage of occupational therapists in Vermont, and I'm asking for your support of H 247, which is the Occupational Therapy Licensure Compact Bill. The compact bill will allow occupational therapists and occupational therapy assistants who are licensed in other states to come to Vermont and begin their employment positions more quickly. The OT compact will especially aid military personnel who often relocate from state to state and are required to have an occupational therapy license in each state in order to practice. The compact will allow licensed OTs from other states to provide telehealth services for Vermont clients who have not been able to find in-person services. What type of healthcare services do OTs provide? Occupational therapy helps people across the lifespan to live their lives to the fullest, to participate in the things that they want and need to do through therapeutic use of everyday activities. For example, OTs help children with disabilities who participate fully in learning, self-care, and social activities in school. OTs help people who are recovering from injury to regain skills that enable them to return to independence at home, at work, and in their communities. OT provides support for older adults who are experiencing physical or cognitive changes to be able to age in place safely and maintain the highest level of functional skills. At this time, Vermonters are going without services since there are unfilled OT positions in medical centers, regional hospitals, skilled nursing facilities, long-term care facilities, home health agencies, early childhood programs, public schools, as well as mental health hospitals and agencies across the state. There are over 180 occupational therapy and occupational therapy assistance positions that are presently open in Vermont, according to the Indeed employment listing that I just looked at this morning. Children and adults across the lifespan are going without services for OT here in Vermont. The OT Compact Bill H247 will bring more qualified therapists to our state. Now I want to pass the microphone to Ella DuPont, who will speak about her experience as an occupational therapist practicing in Vermont.
Hi, everyone. I'm Ella. My practice has been primarily in skilled nursing facilities and pediatric and adult home health care. I've been an OT for 23 years, with 18 of those years here in Vermont. So as a practitioner, I came to Vermont 18 years ago as a traveler because of an OT shortage. So this is an old problem that's really coming to a head. I came here and I stayed, which sometimes travelers do, but oftentimes they'll come here to meet a short-term or a medium-term need to help us get through until we can try to find someone. As a therapist, I've worked 3 travel assignments in the state at different points in my career. I've worked in Rutland, in the Burlington area, and in Newport. So I can tell you that the need is statewide. I could put my resume out there and get a travel job in any county in Vermont right now, which is sad. So as a manager and administrator, I had to use travelers to meet the need because we didn't have enough occupational therapists in the state in every setting that I've worked. I had a 4.5-year opening when I was a home health administrator. I could not hire an OT for 4.5 years. I was able to find travelers during some of that time, but there was times when we couldn't meet the needs of people that had them in the home setting. I had a 3-year opening in our pediatric occupational therapy department that resulted in me having to shut down the OT program because I couldn't meet it. And we were not in line with what was required by the state, so I had to close the program. I had a 4-year opening at the SNF that I worked in where I couldn't get staff. And I think that the compact will help us as we really do need more OTs in every setting in Vermont. And, we would appreciate the support so that it would be easier for us to get these staffers as we try to retain and grow what we're working on in the state. UVM started an OT program. It's in its first year, but it takes a while for clinicians to graduate from a doctoral program. They still need 2 years, and then they need a little bit of learning time and some practicals. And in the meantime, we still have 180 plus openings in the state. And each class is only 15 students. So if they all stick around, it's still going to be a little bit before we would be able to fill all of the need that we have in the state. And that we know that people don't always stay in Vermont. Sometimes they want to try their luck elsewhere. So we do need the help now. We want to meet the needs of Vermonters across the whole age spectrum. We didn't stop taking care of people during COVID. We were essential workers. We did our part. We showed up. We really want to take care of people, but we could use the support through the compact so that we have enough staff so that we don't burn ourselves out trying to do everything. So I'll stop there and just say thank you.
Ella and Karen, thank you so much. And that legislation has been introduced into the State House, along with a number of other compact bills that are moving through the legislature. Now we're going to hear from Ed Paquin about an issue very near and dear to our hearts. Ed?
Okay, thank you. I want to, whoops, I'm going to set myself a little timer here. Okay. First, I'll say that I am a 70-year-old him with glasses and what I consider a neatly trimmed white beard. I want to talk about something that touches on transition from school to adulthood, and it touches on our workforce shortage, but it also touches on other areas of importance. And that's the attendant services program. And attendant services give people who have serious physical disabilities assistance with activities of daily living, the real basics: toileting, feeding, bathing, transferring from one surface to another. You know, picture the basic things, and then what's called intermediate or instrumental activities of daily living, the things you have to do to make those things happen. So people with serious physical disabilities in a world of medical wonders and great physical therapy and occupational therapy can increase individuals' functions and do wonderful things, but they can't do everything. And so many people still need assistance. So across the state government's system, there are many different programs that help people. And you know, they range from choices for care to, there's all sorts of them. I want to focus on one that was started around 40 years ago with input from the community. And I focus on it because it's in sync with our motto of nothing about us without us. It was designed with input from the disability community by people who actually need and would use the service. There were differences between this program and most of our other programs. One was that you could hire and direct your own caregivers, including being able to hire family members. Two, when it was originally formed, there was a panel of people with disabilities who approved or disapproved allotments of time for services. And three, one of the most important ones to think about now, it was state and is state funded, meaning you don't have to destitute yourself to qualify for Medicaid in order to get some assistance. But, and this is really key, several years ago, to save money, the program suspended new admissions. Last I looked, there were, I think, 40 or a few less people left on the program. And not to be too cynical, over time, they're dying to get off. Now, so this program is shrinking because no one new can get on there. Now, let's look at youth in transition. Let's look at a person coming right out of high school or right out of college with serious physical disabilities, but a lot of other abilities and the ability to make it in this world if they've got attendant services. What do? Well, I'll tell you, the family better have what I call the talk. And the talk means you are going to have to keep yourself impoverished enough to qualify for Medicaid funded programs. And that means the trip down life's path is very narrow compared to what you had been dreaming about. And so I want people to think about opening up this program. Maybe we have to have a discussion to open it up for young people trying to reach the workforce instead of to everybody. I don't have all the answers, but I will say this. It's an absolute travesty in my mind that a young person has to plot and plan staying on Medicaid to get their basic needs met when they may be fully capable of achieving great things in life. So I'll leave it there.
Ed, thank you so much. We've been talking about that one for a few years, so hopefully we get some movement sometime soon. Now we're going to hear from Diane Drake, and she's going to talk about DEI assessments. Diane? Diane, you're muted.
Oh, hold on one second, Diane.
And there we go.
Sorry about that.
Oh, no, all on me, all on me. So I'll start again. My name is Diane Drake. I'm the director of ARC Rutland Area, a private nonprofit organization providing social services to persons with intellectual and developmental disabilities in Rutland County. Over the last few decades, and since the closing of the Brandon Training School, there's been an increasing number of agencies and non-governmental organizations assisting individuals with disabilities. Recognition of the disabled population as a part of the whole, including them with marginalized and protected groups, is an effort by many people who want the equal treatment of humans. At the same time, the development of principles identified as diversity, equity, and inclusion has sprung up regarding race-based and other definitional groups and is gradually being incorporated into government agencies, the judiciary, and private employers all across Vermont. A necessary prelude to effect social change vis-a-vis these marginalized groups is the collection of basic demographic data so that we can identify in an informed manner and to help overcome past inequities. Unfortunately, it appears that not by design, but by historical accident, the population of persons with disabilities has been and continues to be excluded from this necessary data collection. As such, we deprive essential information necessary to apply the DEI or similar principles to any agency. This data collection omission effectively renders our neighbors with disabilities invisible in the community. A few months ago, back in December 2022, the World Health Organization reported that health equity for individuals with disabilities is still lacking. It reports that these people, quote, continue to die earlier, have poorer health, and experience more limitations in everyday functioning than others, end quote. The CDC has similar findings for Vermont's adult disabled population. And this is not to disparage the excellent hard work of all agencies working directly for the benefits and rights of Vermont's disabled population, but rather to notice all other government agencies who take on the mission of employing the principles of DEI or similar principles, that they must first ask about all persons when creating the data to be collected for these principles. Without the complete inquiry, the inequities will continue despite their good intentions, and the health of the people with disabilities will remain as they are today, poor. We must recognize that the collection of data is a benefit done for the purposes of correcting inequities, as well as providing transparency and accountability. When the state of Vermont, through any of its agents, collects, reports, and publishes data, it must collect data on all. So the Common Benefits Clause of the Vermont Constitution at Article 7 states that Vermont's government may not confer a benefit only on a portion of the community. It must confer the benefit to all. It reads in part as follows: that government is or ought to be instituted for the common benefit, protection, and security of the people, nation, or community, and not for the particular emolument or advantage of any single person, family, or set of persons who are a part only of that community. If we care to right the inequities upon marginalized citizens of this state, then we must do so concurrently and inclusively with all people, not just those that may be harmed. We must first ask who are included in the population where inequity lies. That who must include the community of people with disabilities. Therefore, it makes a common judicial and economic sense that when employing the principles of diversity, equity, inclusion, or similar principles to correct past equities, that all government entities should, A, include persons with disabilities and their variances in all data collections, specifically when identifying disparities for purposes of employing these principles of DEI or similar principles. And B, perform these collections in a uniform manner to ensure equity and transparency in any published report. Finally, it may also make common judicial and economic sense for the state to create another benefit that features a statewide central database that includes the collection of disability type, age, gender, ethnicity, including indigenous populations, and have it housed in an easily accessible location. When published, it should record all people with disabilities in Vermont receiving any service or benefit from any agencies, including that of being held in correctional systems. Thank you for your time and consideration listening.
Diane, thank you so much for that information. And just to let folks know that if there's any documentation that we are speaking from today, we can make that available if you'd like after today. And now we're going to hear a little bit about what we are terming COVID equity. And we're going to hear from Kate LaRose.
Great, thank you so much. Nick, may I have access to screen sharing?
Yep, go ahead.
Thank you. Let's see. Okay, is that all set for folks?
I just want to check with interpreters.
Renee's interpreters are all set.
Okay, thank you. Go ahead, Kate.
Thank you. Good evening. My name is Kate LaRose. I am a middle-aged white woman with long brown hair wearing glasses, and I serve as the statewide pandemic equity coordinator with the Vermont Center for Independent Living. At VCIL, we are people with disabilities working together for dignity, independence, and civil rights. Our work includes assessing and responding to the current pandemic-related issues Vermonters with disabilities are experiencing, including for COVID long haulers, develop resources and community, and supporting people in advocating for equal access to education, healthcare, and civic life. While we all wish that the pandemic were over, that is simply not the case. Instead of a decrease in death and disability, we've arrived at a perverse plateau in which the ongoing harms hold steady over time instead of coming in waves. We are told this normalcy of harm to people with disabilities is encouraging. And we continue to be in the midst of a mass disabling event. And yet we are repeatedly told by national and state leaders that this is progress, that we have all the tools we need to protect ourselves, and that it's time to go back to normal. In reality, we have done nothing more than to rebrand staggering levels of illness and death as something that is both expected and welcomed, the human sacrifice that must be paid by some in order to suit the desires of the majority. When our leaders tell us that COVID is something that we should learn to live with, what they actually mean is that it is something some of us should just learn to die from. We are told that COVID will weaken over time, despite the fact that it continues to become more transmissible, and risk of complications increase with each subsequent infection. And the tools that we are constantly told that we have, they are burdensome to access or kept from us, and are becoming less effective and are being pulled from the market because they no longer work. The simple and cost-effective measures that continue to be effective, such as the use of masks in congregate and healthcare settings, are not having people work in those settings while they are positive, have been cast aside. Yet current policy response provides nothing more than empty platitudes in the face of harm, with the highest costs being paid by Vermonters who are older, disabled, Black, Indigenous, people of color, rural, or low income. And beyond the immediate impacts of harms of increased infections, hospitalizations, and deaths are the enduring impacts on the day-to-day lives of those being driven into isolation. Over the past 3 years, many disabled Vermonters have been pushed out of education, work, and civic life. All that we had left was healthcare. Now that's been taken from us too. VCIL just completed our annual survey of peers around the state. The results indicate that while the majority of those we serve are continuing to take high levels of precautions to protect themselves, half have had COVID at least once, with the majority of those infections happening in year 3 of the pandemic, when we no longer had access to protect ourselves outside of our homes. We also asked about the impacts COVID continues to have in their daily lives. Many are still unable to safely visit with family and friends, go to the grocery store or pharmacy, access medical care or other necessary activities such as voting, and are being shut out of work, volunteerism, and education as a result of policy-based discrimination. In October of 2022, the Disability and Health Journal published a piece titled "Ever-Changing but Always Constant: Waves of Disability Discrimination During the COVID-19 Pandemic in the United States." The first wave of discrimination was healthcare rationing. The second was lack of equitable access to resources, supplies, and accommodations. The third came in the form of vaccine access. And the fourth wave is happening now. More people being infected with the virus means more COVID long haulers. Many find themselves suddenly navigating the day-to-day realities of living with a disability, including interpersonal, medical, and systemic ableism. And as they journey through, they must be provided a connection to and a rightful place within the broader disability community. I could talk for hours tonight about the concerning data and policy failures that are harming us, about simple evidence-based and cost-effective measures that could save us. But instead, tonight we need to have a heart-to-heart here in the disability justice community. We need to talk about why disappearing allyship in this moment of pandemic inequity is causing harm, why lack of inclusion within these spaces hurts the most. To frame that conversation, we need to go back to our roots. The federal civil rights protections granted to disabled people today exist because they were hard fought and won by disabled people. Here are just a few of the individuals who helped secure these protections for us all. Judy Heumann, mother of the disability rights movement. Ed Roberts, father of the independent living movement. Justin Dart Jr., godfather of the Americans with Disabilities Act. Johnny Lacey, co-founder of America's first Center for Independent Living in Berkeley, and a leader in introducing intersectionality to our collective work. Paul Longmore, leading disability history scholar. Sue Williams, co-founder of VCIL and fierce advocate for disabled Vermonters. One of the things all of these incredible leaders have in common is that they were polio survivors. The history of disability rights in the United States is also the history of post-viral illness. This must be amplified in this moment at a time when social death is again being inflicted by allies and friends alike. In this moment, we need solidarity in the work ahead. The end of the public health emergency does not mean the pandemic is over. It simply means the burden of harm has now been shifted to those who are the most vulnerable. And there must be a place at the table for disabled people who continue to be at high risk of harm from COVID and for long haulers. We are your neighbors too. I leave you today with the words of Dr. Tedros Ghebreyesus, director of the World Health Organization. No one is safe until everyone is safe. Thank you.
Hey, thank you so much for that inspiration. That was great information to have. And now we're going to hear from the Peer Advocate Coordinator, Nate Bazzaio at VCIL about durable medical equipment.
Just one
Nate?
second while I get everybody on screen.
Are we good?
Looking for Nate. I know you're there.
I'll wave.
Wave harder. Oh, bear with me. I'm getting there.
Is that Reese we can hear?
Are we there? Can you?
Okay. Thanks for your patience. Go ahead, Nate.
No problem. Thank you for having me. My name is Nate Bazzaio. My pronouns are he, him. I have short brown and it seems like ever graying hair every day. I have a close cropped beard and a gray shirt. I am a peer advocate coordinator for the Vermont Center for Independent Living in the Burlington office, and I am also a person with a physical disability myself. I use a power wheelchair and I depend on durable medical equipment to help me with my life every day. And I would like to talk to you about a very growing, disturbing issue that we have all been noticing today. And I keep on hearing a theme during the day where it is something that has been a long-term issue, and it seems like it is now coming to a head, either due to COVID, and that's something we have been hearing a lot today. But this has to do with durable medical equipment. By durable medical equipment, I mean wheelchairs, I mean power wheelchairs, push wheelchairs, scooters, hospital beds, things that people with disabilities depend to help them do their everyday life activities. It is essential. And the issues that we are noticing is that there's a lack of places and ability to get the durable medical equipment in general itself, or to get pieces replaced. I noticed this trend when working with peers, where I would hear, I have a power wheelchair that needs the battery replaced, and I can't get anybody to replace it. Now I'm in danger of not being able to go anywhere. I used to be able to get these with fair ease. I used to be able to work with the various medical vendors, but now nobody will be getting back to me. Somebody said I was just prescribed a new wheelchair. I went to get fitted. It was prescribed to me. I'm supposed to get this chair. I haven't gotten it. It's been 6 months. And it's been something I've been hearing across the board, ever increasing. I then found myself personally experiencing this myself. I had something break on my power wheelchair. The vendor who I'd been to for a long time got closed, which meant that I really had to limit the number of vendors that I was going to. So I have been waiting months and months and months for a part. And not only am I not getting the part, I'm not getting a response from the vendor. I've basically been shut out. They won't get back to me. They won't return my calls, and they won't return anything. So this is a growing issue. And the question is, why is this happening? Why are vendors closing down? When I was younger and I had an issue with this, I got 3 or 4 vendors that I could go to. Now I can say up here in the Chittenden County area, there's one. There's one vendor, and there might be another vendor. Why is there only one vendor here? Is it they can't get the people to do it? Are they not getting the reimbursement rates? What's going on? Why? I will say that there are also a couple other places that can do some of the work, but they don't take insurance. They say, we will do this, but we have to pay us directly. I can tell you now, for a lot of people, that's not an option. Replacement batteries cost about $400. It's not an option. So the other thing is, if you're on Medicaid and getting the parts, your option is really only to stick with places within the state. So you can only get state vendors. So you can't take those dollars and say, I want to go find a vendor that maybe I can go order for that's right cheaper and use my Medicaid dollars to get that. You can't do that. So right now I am asking for help in reaching out to these vendors, finding out why this is the case. Why are some businesses that used to sell durable medical goods not doing it anymore? Why is it withdrawing? What are ways that would allow people to have more options to be able to get the goods that they need, get the repair? Because these products are essential for people to leave, to be independent, to interact. And once again, I just like to repeat what I said before. This is a growing theme in a lot of areas. It has been a long time issue that has been coming to a head. So I like to invite a more open discussion on ways that we can fix this issue. Thank you. That is all.
Nate, thank you so much. And you are correct. There is actually legislation about this repair and certain restrictions on being able to do that with all sorts of equipment that people need and use and work with. Now we're going to hear about youth transition, and we're going to hear from Lexia and Safakor about that.
Thank you, Karen. Hi, everyone. My name is Safakor Kumabupumei. I'm the Independent Living Coordinator at VCIL. I work across the state with all students transitioning between the ages of 14 to 26. And with these students, one thing that I do practically with them is to empower them to build their self-advocacy skills and strategies. And very interestingly, we have some of our students who know they have IEP or they meet a team at some point, but they don't actually know what they have. That is, they don't have names for their disabilities. And some also just know that they tell them that you have to meet that group, or you have to maybe listen to what your mother or your parents come back to tell you after meeting that group. But my work with these students is to empower them to be part of that meeting and also to vouch for themselves, to be able to talk for their rights. And one great person that we have today to talk about some practicalities of this journey is Lexia. I just want to give you a little bit about Lexia. I'm so proud of her. Lexia, I'll be working with her for some time now. Lexia Stanley is the full name, graduated high school in 2021, and is now majoring in elementary education with a minor in neuroscience at Plymouth State University. She was an active member of the IEP, as I said, and now she's a great self-advocate. And she also mentors other students through the TRAIL program after herself was a mentee last year. Lexia is also an active member of the Youth Advocacy Council, which I co-facilitate with her ability. And there we empower this youth to talk at state level. In other words, to do the advocacy work after knowing themselves, owning their disabilities, embracing themselves, making that next move to the state level, talking of advocating for systemic changes. So without much ado, I will just introduce Lexia to you to say hi, and I will be asking her questions as she walks through her journey with these questions. Lexia, would you like to say hi?
Hi, everyone. For visual reference, I'm a dirty blonde, so I have brown and blonde hair. I'm wearing pink headphones to listen to everyone's stories tonight, and I'm wearing a tan colored t-shirt.
Thank you. Thank you so much. Thank you for reminding me. So I'm a Black woman with a rasta roll up on my head. Thank you, Lexia. So quickly, would you like to tell us or describe your experience on your IEP team in high school?
So I know one of the other questions was about employment, but should I touch on the IEP one first?
Yeah, let's go with this experience, then we come to the employment.
Okay. So I was fortunate in elementary school and high school rather, to have a great IEP team. For background, I was diagnosed with a nonverbal learning disability in May 2012. I was 8. At 8 years old, I wasn't sure how I should process this because I was a 3rd grader. I didn't have really many services available at that point because it was close to the end of the school year. So I didn't really have advocating for myself until my 4th grade year of elementary school. I didn't actually begin advocating for myself till about the second half of my 4th grade, or maybe even 5th grade year of school. If I were to change anything, I would have wanted to advocate sooner, because for those first couple of months in school with getting my IEP written, I would just sit in the meeting and sit there and be quiet and just let the adults run the show and not really say anything, until I realized the importance of advocating and I realized I need to speak up and say something. So I finally did learn those skills over time, and I have very strong skills now.
Thank you so much. If you have anything to change around that, what would that be?
As I mentioned, I would advocate sooner so I could have better personal knowledge for what I needed at the time.
Thank you. So what Lexia is advocating for here, one is to make sure that our advocacy strategies should start as early from kindergarten. Okay, so what were some of your employment and independent living goals for after high school?
So after high school, as Sefcor mentioned, Plymouth State University is where I'm calling from tonight. This school and making the choice to come to college is one of the best decisions I've ever made in my life journey so far, because I've made great connections. I've met wonderful people. I've made many memories here, and I've shared a lot of memories specifically with the friends that I've made. For high school wise, I did want to get a job. I've wanted to work since I was the age of 14, but because in my neighborhood there wasn't really many kids that were young enough for babysitting, I decided to just wait until I was 16. That's when I started working at Manascutney Hospital in Windsor, Vermont in August 2019. I've been working with Higher Ability since then as well, maybe even August 2017 or even 2017-2018 school year. And they've been helping me quite a bit with financial needs, with my schooling. They gave me $5,000 for a grant towards my first car that I've had for about a year now, almost 2 years, will be 2 years in August. I also get $600 grants every semester for my school supplies. Other organizations and organizations that have helped me would be VCIL and Vermont Family Network through the Youth Advocacy Council that Sefcor and I are on together.
Thank you, Lexia. Finally, did you ever have to advocate for an accommodation, and what was that experience like?
So I never thought I would actually have this experience, being that I've had this diagnosis for over a decade now. I did not ever think this would come up, but unfortunately last semester for college, it did. I had a personal financial planning class, which went over the basics of finances and how to budget and different things like that. And I went to the professor within the first couple of weeks of school and said, "This is what I need. Can you help me out?" So he decided to essentially ignore what I had to say, because one of the things for that class was a $105 program that I needed in order to complete the class, because that was what the course was centered around. So I did not end up getting any sort of extension, and unfortunately I fell behind by about 2 weeks than everybody else because I couldn't afford it at the time of the semester beginning. So I ended up getting money support from my parents, and I was able to stay caught up enough. It took me a few weeks, but I was able to get caught back up and able to pass the class and move on with that. I also have noticed, not really an accommodation, but I've also noticed I've been stereotyped a lot for not having a disability, because I don't show it that well, because it's an invisible disability, because it affects my brain and mentality a lot with social interactions and academics when it comes to reading comprehension, among other things, and my writing skills as well. So being stereotyped over the years has definitely not been a benefit to this, but I was told by one of my supervisors last year that I had for work at school. They said, "You're not," during a training, they said, "You're not you're not your disability, you're the ability," and that stuck with me ever since.
Thank you very much, Lexia.
Thank you both. Thank you both so much. We're going to have to unfortunately move on, so we have time, but thank you both, Lexia and Sefcor, so much for speaking tonight.
Thanks again for that to the both of you. We're going to now hear from Wilda White, and she's going to talk about rhetoric on mental illness in the State House. Wilda?
Oh, just one moment while I get everybody in view.
I'm here.
Okay.
Thank you. Is it okay to start?
Give me just 1 second. I'm just making sure I have the interpreter and you. Yep, go ahead.
Thank you. My name is Wilda White, and I'm the founder of an organization called Mad Freedom, which is a human and civil rights advocacy organization whose mission is to secure political power and influence to end the discrimination and oppression against people based on their perceived mental states. One of my first experiences advocating on behalf of people who are perceived as having mental illnesses, or I'll also use the term psychiatric survivors to refer to people who are considered to have a mental illness. But one of my first experiences advocating on behalf of psychiatric survivors in the Vermont General Assembly took place in 2015, when I was trying to get Representative Ann Pugh, who at the time was chair of the House Human Services Committee, to allow psychiatric survivors to testify on a bill that would have made it easier to forcibly drug people with psychiatric diagnoses. It was really difficult to get any time with her, just to even ask for time to testify. But I noticed that after every hearing, lobbyists, in particular Jill Massa Olson, would go up to her and say, hey, can I walk with you after hearing and talk about this bill? And she always said yes. And so I decided to do the same. And I went up to her and I said, hey, can I walk with you to talk to you about this bill? And she told me that I needed to get away from her, or she would call the Capitol Police to remove me from the building. Representative Pugh is no longer a state representative, but the hostility towards psychiatric survivors that she displayed that day persists in the State House. While no one has threatened to have me removed by Capitol Police, the rhetoric and language used in the State House about psychiatric survivors and our exclusion from hearing rooms as witnesses, particularly in the Senate, has not changed. Just this session, at least 4 bills passed in the Senate directly affecting the constitutional rights of psychiatric survivors. All 4 of the bills passed without any invitations extended to psychiatric survivors to testify on the bill, and without taking any testimony from psychiatric survivors or the organizations who advocate on our behalf. Those bills included S36, S89, S91, and S46. The bills were heard in the Senate Judiciary Committee and the Senate Health and Welfare Committee. And I expressly asked to testify in Senate Health and Welfare, and I didn't receive a reply to my request until after the bill had been voted out of the committee, some 2 to 3 weeks after my request. This exclusion has meant that our voices are not heard, our perspectives are not considered, and our experiences are not taken into account when the legislature makes critical decisions about our lives. Additionally, the language and rhetoric that are often used when talking about individuals with psychiatric diagnoses are often stigmatizing, discriminating, inaccurate, and harmful. Too often, individuals with psychiatric diagnoses are only talked about in terms of their potential for violence or criminal behavior. This is an unfair and inaccurate representation of the overwhelming majority of individuals with psychiatric diagnoses, and it's time for the legislature to recognize the full humanity of individuals with psychiatric diagnoses and to stop perpetuating harmful stereotypes. One of the most important ways that the legislature can begin to change the way it views and treats individuals with psychiatric diagnoses is by inviting us to testify on bills that directly affect our lives and our rights. The exclusion of our voices and experiences is unacceptable, and it is time for the practice to end. Only by listening to our experiences can the legislature make fully informed decisions that consider our needs and our experiences. Today, I'm urging the legislators and anyone who has a legislator's ear to talk to your colleagues about adopting a practice of always inviting individuals with psychiatric diagnoses to testify on legislation that directly affects us, and to change your rhetoric and language when speaking about us. By doing so, the legislature can foster a more equitable society that recognizes the values and needs and experiences of all people, including those with psychiatric diagnoses. The time is now for the legislature to create an environment that promotes inclusivity, respect, and dignity for individuals with psychiatric diagnoses. I appreciate your attention. Thank you.
Thank you, Wilda. Certainly something to think about and improve upon. I think that we have probably just a few minutes. We were hoping to have more for question and answers, but I think that we could probably take a few questions if Nick wanted to help facilitate that, and then we'll have a couple minutes to wrap up. So thank you
Sure.
all very much for your presentations.
Yes, thank you. And if you'd like to share something, like I said, you know, we've had so many important presenters tonight, and we appreciate everybody's patience. If you can use the raise hand function, or you could raise your hand and I'll look for you, or also feel free to type your message in the chat, and I will call on you. If something you'd like to share, something you want to share with people about what makes you everyone's neighbor and what's important to you tonight that you'd like to share, or maybe reflecting on something that you've heard tonight. So I will just look for any raised hands, any. Okay, Lexia, I'm gonna wait on you
I
just one
see.
second. Just one sec. I'm gonna get Paula so that Paula can share, and then Lexia. 1 second, Paula. Let's make sure you're unmuted. There should be a little thing popping up telling you you can unmute. How about that? You want to give it a test?
To let
Yep, I can hear you, Paula. Go ahead.
all of you know, this is my first time doing something like this. Many of you don't realize that there's been problems up in Chittenden County. And it's hard for those like myself who've gone through a whole lot more than a lot of you who are on tonight. I'm hoping some of you will reach out and give me a ring on wanting to talk more. It's been hard and frustrated because of some of the stuff that's been going on.
Okay, Paula. Thank you. I hope that you'll continue to share with us, and thank you so much for being here tonight. I know I've talked to you on the phone before, so it's good to see your face. I think we're going to go with Kathleen first, just because we heard from you before, Alexia, but I promise you'll be after Kathleen.
Hello? Can you hear me? I've been on SSDI since the mid-90s because of it's a really long story. But anyhow, it was something that was thought to be like chronic fatigue syndrome, ME, or like long COVID right now, but it was eventually diagnosed 2016 as a structural issue with connective tissue. So I'm classified as an invisible illness, disabled person. I originally got disability through New York State because that's where I was living at the time, and services there were extremely poor. I came here in 2016, a connection to different groups, providers here with my condition. And the services have been better significantly, but still, I would say mediocre. And I'm somebody who's very active in working with people with similar conditions. And it seems to be getting more and more difficult to get any kind of disability support without it being very protracted and a severe struggle. So I was wondering, is there any an invisible illness disabilities is a rapidly growing and emerging category. So I was wondering if there's any, is there any services like through your organization?
Kathleen, this is Nick. I just want to let you know, I actually work with VCIL very closely with folks. So I'm going to put my information in the chat, but because we're about to run out of time, I'm going to connect with you directly. Okay. And, but I'm really appreciate that you shared your story, and let's make sure we connect.
Okay, great.
And I appreciate that Lexia put her hand down so that we can hear from Renee. So Renee, go ahead. Good to see you.
Everyone, my name is Renee Callerin. I'm a white man with white hair and a long mustache. I can't smile because it's so long, it's too heavy. All right. So I'm not here right now to talk about me. I want to talk about several friends of mine who have severe disabilities and are deaf. Those friends are very, very underserved right now. And they have tried reaching out, and most agencies have no idea what to do with them. There's one individual who is finally living independently, and his time, the support that he needed was not, and he didn't know how to get services. And what's needed is staff who are fluent in American Sign Language who can serve him. And the agencies that he contacted said, we can't afford to pay for staff who can sign. So this needs were ignored. And this is happening to several friends of mine. These people are seriously underserved, and it is a major problem. Thank you.
Right. Thank you very much, Renee. And I do, we do have our interpreters and such who are going to need to hop off right at at 6:30. So I invite everybody to, put your camera on so that we can, see you. Karen, you want to wrap this up for us?
Does Sharon, can you let Sharon speak for just a minute?
Go ahead, Sharon.
I couldn't figure out how to get my hand raised.
Oh, go ahead, Sharon.
I'm Sharon. I've been in the disability movement for years. I'm wearing a green shirt. I use a power wheelchair. But I wanted to speak to specifically what Nate talked about durable medical equipment. I am putting a call out right now for people to email me with their stories. I am on the Medicaid Exchange Advisory Board, and the commissioner is willing to meet with me. I also am acting chair at this point, and it looks like in May we're going to have a robust conversation about this. But if I don't get the individual stories, what they're going to say, and I will be perfectly honest with you, is that my story is just one. So it's just anecdotal information. I need folks to email me. I'm at Karen76@gmail.com. I meet on next Monday with the Medicaid Exchange Advisory Board. It is extremely important that I get these individual stories under medical equipment. And I can't figure out how to put my email in the chat.
It's okay, Sharon. Can you give me one more time and I'll put it in for you?
Sure.
Oh,
It's
it looks like Susan did. Okay, so it's Susan Aronoff put it in the chat for you and we'll make sure.
Right. I put Hanalt Sharon76@gmail.com.
Yes, thank you.
Okay.
Great. All right.
Karen, thank you so much for that, and we'll hopefully you'll get some responses to your question. Thank you for participating. I guess we're at the tail end and we're just exactly at 6:30. I just wanted to thank all of the presenters for a very interesting mix of issues and stories. And we really appreciate you doing that. And then to all of our neighbors who attended, legislators and administrators and self-advocates and providers and friends and allies. We really appreciate your attendance, and if you have any questions or concerns, you can always get a hold of a VCDR, get a hold of Nick or myself, and we'd be happy to help you with that. So thank you so much. Have a lovely evening and a good next day.
Thank you, everybody.
Thank you, everyone.
Thank you.
Have a good one. Thank you.
Take care. Thank you, interpreters, captioners, and everyone.
Thank you. See you at Voices and Choices.
Yay.